Hello, my name is Sabine Girod. I'm the Chief of Oral Maxillofacial Surgery here at Stanford University. And today I would like to talk to you about the aesthetic and functional jaw surgery and basically get you familiar with what's out right now and what's new and exciting about this field. What I will be talking about is the aesthetic proportions of the face. What do we actually feel is nice or good looking when we look at a face? Then how the facial skeleton affects our appearance and problems in the facial skeleton can actually disturb our appearance. And then I will go into oral maxillofacial surgery and talk to you about my specialty and tell you a little bit about what we call orthognathic surgery, which is relatively invasive surgery to correct deformities of the face. I will also talk about distraction osteogenesis, which is less invasive. And in the end, I will be talking about orthodontic distraction, which is a new minimally invasive method to correct craniofacial deformities. At this point, this will all sound to you very unfamiliar, but during the talk, I hope I will be able to explain to you how these different surgical methods help people who have facial deformities whose face is not really balanced to achieve balance and beauty in their face. Let's look at a couple of examples of very aesthetic facial proportions. Of course, if you look at this very old bust from Egypt, which probably everybody of you knows, you can see that this is a very beautiful woman. Why do we think this woman is very beautiful? Actually, Albrecht Dürer, even in the 15th century, already decreed that if we have the 3/3 of the face, if they are balanced, then we have a very beautiful face. And he made these beautiful drawings, which are from a book that he published in the end of the 15th century. And you can see here, if you look on the right, if the lower part of your face and the middle part of your face and the upper part of your face are in perfect balance, then most likely every single one of us will think that this is a beautiful face. Some people don't have these balances, and these are two people where you can see that the facial balance is not normal. One of the people has a very small mid-face, and the other person has a very big mid-face in combination with a very small lower jaw. And of course, if we look at this, we think this is not perfectly beautiful. The other thing is that if symmetry in the face is very important. So this is, of course, the picture of the famous Mona Lisa, and you can see if you put a straight line through her nose that she has a very symmetrical face, and we perceive this as very beautiful. And there are other attributes, especially in women, that are felt by the usual observer as being very beautiful. These are, for example, large eyes, the prominent cheekbones, blue eyes, like in this patient on the left side of the picture here, and on the right side you see a famous actress. And you can see that both profiles seem to be very similarly attractive. But then if you look at the rest of the face, and this comes back to what I talked about before, that you have to have facial balance, you can actually see that at this point we don't think that the left face is quite as attractive as the right face. And really what we do in oral maxillofacial surgery, we correct these imbalances by surgery in the face. And that's the specialty that I want to be talking about. So how can we achieve this facial balance that I've been talking about? If you look at this person here on the screen, you can see that the mid-face, the middle of the face, seems to be rather small and sort of look going backwards. And we don't think, and it seems like the jaw, the lower jaw is really big. So this is really determined by the skeletal and dental structures that are underlying the soft tissues in the face. And you can see here an X-ray, and then the next thing you can see the dentition of this person. And you can see that actually, as if you're an expert like I am, you can see that the upper teeth are behind the lower teeth, whereas normally the upper teeth are in front of the lower teeth, and this would be a normal facial balance. In oral maxillofacial surgery, we do a lot of analysis about this. So we basically do, you saw the picture of Dürer, what he already did in the Middle Ages. We do the same thing. We measure the balances in the face with an analysis that's called a cephalometric analysis. And that basically tells us where the deficiencies are, where the imbalances are. And every patient that comes to our practice, we look with this cephalometric analysis how we can change the facial balance to make it more normal, quote unquote. Of course, we also look at the teeth. There's another example. If you look at this young woman, you can see that her face seems to be asymmetrical. And I just want to show you how the skeleton underneath determines the patient, what this young woman looks like. And you can see here on the right side a video, and you can see that this part of the as what we call the ascending ramus of the jaw is relatively small, and it's smaller than the same part on the other side, and that makes the lower jaw sort of out of balance and asymmetrical. And we can correct these kinds of asymmetries by doing oral surgery. Another thing that you can see in people's faces sometimes is, for example, like this one. This woman has a very small lower jaw, and what you can see here, and you see the red arrow there, that she has sort of this dimple or divot in the lower jaw in this area. And you would think, well, if she went to a plastic surgeon, we would just do an augmentation. We would put some foreign material in there and make this chin look different or better. But if you look at her dentition, you can also see that the upper teeth are like buck teeth, sort of go straight outside of the face. And especially on that little photo on the right lower side, you can see that there is an imbalance in the dentition. And this is really what makes that little divot on the outside. And if you move the jaw forward, you can actually correct this. And at the same time, you can make the bite better, which is the functional advantage. Here's another example. This is a young woman who again seems to have a very big lower jaw and a relatively small midface. And again, if you look at the dentition on the lower right here, you can see the red arrow, and you can see again that the upper teeth are behind the lower teeth, and that's not normal. And part of the reason why she has this facial profile is that her dentition doesn't fit. Of course, she also cannot bite really well. So when we do those surgeries, we are not only looking at the aesthetics of the face, but we are also looking to make the functional occlusion, what we say, the way the teeth bite, work better. So how can we do this? This little video shows how we move the jaws around in order to change the facial balance. You saw the patient before, and now you see what he looks like after when the jaws are moving around. So basically by doing these surgeries, by bringing the upper jaw forward or backward or changing the symmetry, we can change the facial balance and make the facial balance more aesthetically appealing. And of course at the same time, and that's very important, we also influence the functional side, which is that we can make the people bite better, and so the functional, nutrition and everything is going to be better for them. So let me go a little bit more in detail, just not to bore you, just to show you a couple of slides of how these surgeries are done. First of all, everything is done from the inside. There are no outside scars. So we're basically going, all the surgical cuts that we made are made through the mouth. So there are no aesthetic changes in the outside of the face. And this is what I talked about, at the first slide, where you probably were very, sort of not understanding what this is. This is what we call orthognathic surgery. It's basically, a lot of people have braces, and the person you go to is an orthodontist. And if you do surgery in the jaw, you do orthognathic surgery. Gnathic is the jaw system. Yeah, and you can see here in these couple of slides what we do. So again, we go in from the inside where the wisdom teeth are, and we can do what's called here a lateral sagittal split. Yeah, and you can see here that we split the jaw, and then we can move the jaw pieces in order to correct the jaw if it's too much forward or too much backwards. At the same time, we can also do the jaw surgery in the upper jaw, and we call this a Lefort osteotomy, where we go in under the lip and loosen the upper jaw from the midface and move it backwards or forwards. Now you will ask yourself, how are we stabilizing this? And a lot of people are very worried about being wired shut. So in the last 30 years we've made, or since I've been doing this in the last 20 years, we have made a lot of progress in how we stabilize these kinds of situations. And you can see that on this X-ray and little video here. We use these really small little plates, and you can see them also here in the video. And these plates are actually stable enough so that we don't have to, quote unquote, wire anybody shut anymore. These plates are stable enough that you can open and close your mouth, and all we need to do is wear some light elastics. For the first 10 days, of course, you cannot really move your mouth very much because we want you to settle into the new occlusion or the new bite. But after that, you can eat a soft diet, and there is really, you can take these rubber bands out at any time because these plates are stable enough to stabilize the jaws in the new position after the surgery immediately. So what is the postoperative course for our patients? Like I said, usually for 10 days, these elastics have to be relatively firm, and you can really only eat a liquid diet, and then after that, a soft diet is perfectly adequate. But these little elastics can come out anytime, so you never have to be wired shut, quote unquote, anymore. Let me show you a couple of examples. So this is a young man, and when you think back of what I've started out with, the facial balances, you can see now from what I've told you that this young man has a relatively big lower jaw, relatively small mid-face, and if you look at his teeth on the upper right, again you see that the upper teeth are behind the lower teeth, and normally the upper teeth would be in front of the lower teeth. So what did we do? We moved his upper jaw forward, we moved his lower jaw backward, and you can see that he has a completely different profile now. So we completely changed his aesthetic profile, and the good thing is also, and you can see that on the lower right, which is actually our primary goal, is that we also want to bring his teeth into a bite that he can function normally for the rest of his life. And you can see that he has braces in place. All of these surgeries, or most of these surgeries, are always done in connection with an orthodontist who helps us with the braces to basically adjust the teeth as much as he or she can. So this is another example, again, the same situation, a young man with a very long face. Remember, we talked about the thirds in the face, and if you look at him, clearly the lower third is almost 1.5 times too long in comparison to his mid-third and his upper third. We talked about these thirds of the face that have to have about equal length in order for us to think that this is, or perceive this as an aesthetic pleasing face. And you can also see on the right side, again up there, that his upper teeth are behind the lower teeth. So we want to correct that as well. So what do we do for him? This is the young man right after surgery, and you also can see the elastics that he is still wearing. And you can see what kind of changes we can achieve with this type of surgery. We actually made his lower face much, much shorter. And you can now see that if you look at the facial balance of those thirds, that we are much more approaching or much closer to this sort of aesthetic ideal that we talked about before. And also, if you look at his profile, you can see that his mid-face came forward, his lower face came forward, and that he has a more normal projection of his jaws in the side view. The other thing, when we do these surgeries, you probably heard a little bit about from some people who have sleep apnea. So this is a young man who actually suffers from very severe sleep apnea. So that is, he wakes up multiple times at night, and in the long run, this is not a condition that you really want to have. And on the right side, you see this X-ray here, and on the X-ray you see his airway in pink. Yeah, just try to remember the airway. Yeah, his airway is relatively small, and that the reason for that is that his lower jaw is too small. If you looked at him before, you see that his lower jaw is really very, very far backward and impinges his airway. Imagine he's lying down and his airway collapses and he cannot breathe at night and wakes up in order to breathe. So we did his surgery for him, and now look, the pink area is almost doubled. So what we did in this case, we brought his lower jaw forward, and you can also see his profile on the left side, that now all of a sudden he has a much better profile. The jaw is much more normal in his profile at this point. And the most important thing is that his airway is open and he's cured from his sleep apnea with this surgery. And there are a couple of words on that I may want to explain. Mandibular hypoplasia means basically that the lower jaw, the mandible, is very small, and the BSSO is the lateral split osteotomy that I showed you before in those little schematic drawings. Let's do a little excursion into sleep apnea because we just started talking about that. Obstructive sleep apnea currently affects about 30 million people in the United States. About 10% of all men and postmenopausal women are affected, and 1 out of 4 are actually very thin. But only 3 million of those people are treated. The problem with obstructive sleep apnea is that the airway is too small, and we can correct this with this type of surgery that I just showed you in this young patient's example. The problem is really that these people in the long run, people who suffer from sleep apnea, tend to have hypertension and heart problems in the long run because they cannot really sleep at night and they wake up multiple times. They're also very tired during the day. They can fall asleep at the wheel. So this is one of the entities that need to be corrected, and a lot of people go on what's called CPAP. They wear a machine that breathes for them at night, or we can correct it with this type of surgery. And basically the same principles that I talked to you about orthognathic surgery that we just discussed apply to this surgery. So we bring the upper and lower jaw outward and open the airway in the back, and that way cure the patients. This is just some example. Of course, if we bring the upper and lower jaw outwards, the big problem is that we also want to make it in a way that is aesthetic, right? And this is just an example of a young woman who was suffering from very bad sleep apnea, and the numbers on the left side show how bad her sleep apnea is. Just look at the AHI, or these numbers here. You can see that they're much improved after the surgery. And on the right side, what I wanted to show you is that bringing the upper and lower jaw out can also have very positive aesthetic effects. Yeah, so we always try to look, or actually I always try to look at correcting the function, but at the same time do it in the way that makes the patient look good, or take into account the aesthetic appearance of a face when we do these surgeries. Again, we do these big advancements, and you can see here how the airways are open, what kind of hardware we are using. We're using a little more hardware than just those little plates like in orthognathic surgery. That is also, the reason for that is that we're doing these very, very big advancements, and they need to be stable. So they need to be stabilized a little bit more, and we also, again, do not want to wire anybody shut, so we use a little stronger plates. So now we have talked about the orthognathic surgery, which is really sort of the big surgery that's relatively invasive. You're usually in the hospital overnight or maybe 2 days, and there's some swelling, some swelling and some healing involved. Let me talk about another possibility to correct facial deformities, which is called distraction osteogenesis. So the principle was actually discovered by a Russian surgeon, and that is when you make a cut in the bone and you pull it apart slowly, like 1 millimeter a day, like you can see on the right side, there will actually bone will be growing in between those cuts. And that's where the osteogenesis comes from. So if you pull slow enough on a leg, for example, that's too short or something like that, then you can actually pull the leg and make it longer, because the bone spontaneously regenerates in between those two segments. Yeah. And the same principle has been applied to jaw surgery. We have these little distractors, as we call them, the little metal things that are screwed on the bone. We make cuts and then start pulling and create new bone that way. So this is the principle. You have a jaw, for example, that's too far backwards. You can see here, I don't know whether you remember the one lady with a little divot here in the chin. You can see here on the left side that you basically put this distractor on, and then you start pulling, and on the right side, on the right picture, you see after distraction, and in between those cuts, there's a new bone that spontaneously regenerates. Yeah? So you don't need to make any cuts or put any plates in, you just distract the bone and create new bone. You can also correct facial asymmetries with that by basically putting, for example, a distractor just on one side and just start pulling the jaw over. Yeah, so you can correct with this distraction, you can correct facial asymmetries like in this lady. On the right side, you can see that her chin is very much pointing to the right side, and on the left side after surgery, she has a very nice midline after the surgery. And the other thing is that if we have very big discrepancies, like in this young woman who has a cleft lip and palate, we also like to use this distraction osteogenesis because we want to gently pull things forward, because there's a lot of scarring from the prior surgery. And distraction osteogenesis is actually a little bit better for these kinds of things than just doing it in one surgery. And so she was corrected with that. So basically, again, we loosen the upper jaw and bring it forward with the distractors in place. Let me just show you an example. So this is a gentleman who is suffering from a very severe condition that basically caused his upper jaw to stay in a certain position and then his lower jaw to grow. So you can see that he has a very big discrepancy between his upper jaw that's very small and his lower jaw that's very big. Yeah, on the right side there's also a little video that shows that. And so we did this distraction for him. We went in from the inside, again, no outside cuts. We put the distractor on, made some cuts, and then started activating the device over 10 or 12 days. Sorry, and you can see here on the lower left what his face looked like afterwards. You can see especially that the mid-face came forward a lot. He still seems to have a little bit of a puffy lip, but that's a reason for that is that he still has the distractor and we have to take it out and he still has some swelling. Yeah, but you can see that basically his mid-face deficiency, the small upper jaw, has been corrected with this type of surgery. Now let's talk about the last of the 3 points that I initially introduced to you. We talked about orthognathic surgery, which is the big surgery, everything done from inside. We stabilize with plates. We discussed the principle of destruction osteogenesis, which is basically you cut the bone and grow new bone with so-called distractors. I showed you how that can correct, very big deficiencies and asymmetries. And now let's talk about what we can do in order to prevent these conditions in younger people. And we call that orthodontic distraction. I don't know who of you has children and goes to the orthodontist. In some cases where we have these facial imbalances, and we can also see them in children, the children wearing these kind of masks. Yeah, they wear them at night and they're attached to the teeth. And what the orthodontist is trying to do, pull the upper jaw forward in order to prevent or help the growth of the jaw and prevent these conditions that I showed you before. Of course, the kids don't really like to do that. The same thing is what we call palatal expansion. If you had children, you probably have had a child that had a butterfly in his or her mouth, and you had to crank it open. And as long as the sutures in the face are open, as long as you're growing, and for girls it's usually until they're 15, for boys it's longer, 17, 18, sometimes longer. As long as all the sutures, the growth sutures in your face are open, you can basically do these things very non-invasively. And you don't need to do any surgery because you can basically pull on the bones and the sutures will open up and fill in, and you can sort of correct these conditions just by pulling at them without doing any cutting. Yeah, and that's the principle. So this young lady has, again, if you look back, this young lady has a mid-face deficiency. You can see that, again, that this upper jaw is really much smaller than the lower jaw here. Yeah, and she's only about 10 or 11 years old. Yeah, and we know at this point she is still growing, her sutures are still open. So what can we do in order to prevent that she grows up and she still has the same deficiency, and we have to do surgery on her? So now there is a new method that was described by a Dutch orthodontist, and these are some pictures from his book. Remember this, the same little girl about a year later, and all he did was he put some plates in here, and I'll show you how that is done. And he just conservatively with rubber bands pulled her upper jaw forward, and you can see now that her mid-face and her upper jaw came out. She has a much nicer balance. So this is something that Dr. de Klerk discovered that has been sort of known for a while, but he did a lot of studies about that, and this is really the new way of preventing, basically correcting these problems during growth already. And so all we do in these cases is we put some plates under sort of local anesthesia in the upper jaw and the lower jaw. The kids wear these rubber bands 24 hours a day, and what happens is because the sutures are open, the jaws sort of follow the pull, and while the kid is growing, the asymmetry is corrected. It takes a little long, it takes about a year or so, but basically all they have to do is wear these rubber bands. So this is what again, a little, just a schematic drawing, about what the plates look like. And, they just have to wear these rubber bands, day and night. They can eat with it, open their mouth. They just have to take them out to clean. And it's much, much less, obtrusive than, the mask that I showed you at the beginning. And the other thing is also that the plates are pulling on the bone and not on the teeth. So you're not moving the teeth around. You're actually just pulling the whole bone around. And that's the big advantage of this particular method. We now apply this also to our kids that we have in our craniofacial clinic, which is the clinic where we look at all the children that have deformities of their face because of syndromic disorders, or they have cleft lip and palate. And this is a young woman who has a cleft lip and palate. And if you look at the picture here on the very upper right, if you look at her profile picture, again, you can see that she has a very flat lip. Yeah, and that happens when you do cleft surgery. There are a lot of scarring. The upper jaw doesn't grow as much. So again, we put these little plates in there, and we are pulling on her upper jaw so that the upper jaw, while she is growing, comes forward, and hopefully in the future she will not have to go to orthognathic surgery, which is, the surgery, the big surgery that I talked about before. Sometimes we actually have them wear one of these masks at night in addition, just to pull a little bit more and make the pull stronger. This is another young lady, same thing. Yeah, she has sort of a top bite, and we really don't want to go for surgery for her because it's really minimal what she needs. So again, in her case, we also put those hooks in there, and you can see the hooks right there. And all she does is wear these rubber bands in between those hooks, usually all the time. And while she's growing, her upper jaw is coming forward the 2 or 3 millimeters that we need in her case, and we can avoid orthognathic surgery or distraction osteogenesis for her. So she doesn't have to go to any other big surgery. And we can see on this image that this is actually working. So this is, again, what I talked to you about in the beginning, the measurements we call cephalometric analysis. So all our patients, we at certain time intervals, we measure whether our approach is working and how much they're coming forward. So in summary, this orthodontic distraction is sort of a new method, minimally invasive, that we're doing in all our children, where we see that they already have these jaw imbalances. And the reason why we're doing is because it's very minimally invasive. We can do it during growth, and hopefully those children don't have to go into the big jaw surgery when they're adults and fully grown. And we are seeing a lot of success and positive development with that. So this is really the end of my talk, and I hope I could explain a little bit to you what I am doing, what oral and maxillofacial surgeons are doing. Oral is, of course, the mouth. Maxilla is the upper jaw and facial. So it's a very long word, very complicated, but basically what we do as oral maxillofacial surgeons, we do everything from tooth removal, wisdom tooth removal, dental implants, to correction of facial deformities, like what I showed here. And I hope I could explain a little bit to you what the current methods are, how invasive they are, the different successes or changes that we can achieve with these methods. And for me personally, in the end, this is a patient that I had a couple of years ago, and she came in with severe sleep apnea, small lower jaw, and she looked always very tired. And a couple of weeks, a couple of months after her surgery, she sent me this picture, and you can see how she has changed, how happy she is now. She can sleep because of the surgery. She can bite and eat, and she feels was very appreciative and sent this picture with a big thank you. And that's really, the best thing that can happen to a surgeon. Thank you very much.